All right, guys. Today we're going to get through disc herniation for our PowerPoint. Now, if you've noticed, you have YouTube links. Those are private YouTube links, but each one should tell you where you need to go and the link for each topic. Today we're going to be going through disc herniation kind of quickly because I want to get this all on one taping. So disc herniation, what is it? It's a displacement of the disc material or the nucleus pulpus beyond the intervertebral disc space. So you see this right here and through here. This is a herniation. The disc has come out through and is compressing nerves and other parts of the spinal cord. Herniation describes an abnormality of the intervertebral disc. It's the inner core of the intervertebral disc that it bulges out. It may come completely out, it may drip down, but somehow it bulges out through the outer layer of the ligaments that surround the disc or the annulus fibrous. The tear in the annulus fibrous causes severe pain. When somebody herniates their disc, it's not just a slow whatever. If they herniate it, it's going to be sudden onset pain, and it can be herniated from reaching, bending. Usually it's not lifting that causes the herniation. It's something small like lifting to pick or reaching to pick something up or bending over to pick up something light. The tear in the annulus fibrosus causes severe pain. The pain may spread down either leg if there's associated spinal nerve root compression, especially if it's in the lumbar section. You might get that sharp sudden pain that just shoots down the back of the leg. Most herniations occur in the morning because our muscles aren't stretched and warm from working during the day or moving during the day. The two most common locations are at L4 and 5 or L5 and S1, that lower back, because that's the area where most of our stuff or most of we use for strength when we're picking up stuff. Prevalence of a herniated disc? Well, highest between the ages of 30 and 50. We're more active at that time. Male to female ratio is 2 to 1. Males, they lift heavier stuff, so it stands to reason that there are going to have more of a risk for disc herniation. People between the ages of 25 to 55, 95% of disc herniation occurs in the lumbar region. This is due to lifting improperly. We always tell you when you get to nursing school, save your back, save your back. If you talk to a lot of older nurses, they'll tell you, I've hurt my back at least once or twice in my career. Always use proper lifting techniques to save your back. Cost. Back pain is cause for 60% of the missed work days in the U.S. It causes over $90 million, and $26 million is directly related to treatment. And a lot of this stuff causes chronic back pain that just doesn't get fixed. These people live in chronic pain. These are just different tears with different ways. So this is a normal one. Well, now we have a tear with some kind of a bulge. Now we have it where it's actually come back and is compressing nerve root. And this one has completely come out of the disc and it's actually going to start dripping down. This is the bad one. This is the one that they usually have to take out the entire disc and put in what we call as a jack. My son-in-law had to have this done because he was hurt in Afghanistan during a bomb blast. And about 3 months ago, his pulpus was his nerve, his disc was actually dripping down his back, and they actually had to take the entire disc out, and they put a jack in, which is this little device that was just approved by the FDA to hold the spine up. It's supposed to work well, but it's still relatively new. Risk factors for this is aging. Disc deterioration over time and grow thinner by the age of 30. 1/3 of adults over 20 show signs of disc herniation, and with aging, your disc loses moisture and we start to shrink. Hold on one second. Meaning is that we dry out. That's why we tend to lose height as we get older. We don't have enough moisture. Things start to shrink. Our spinal cord starts to shrink. That's why most people as they age can lose anywhere from 1 to 3 inches off their height. Menopause, bone density. As women, we lose our bone density. The bones start to crumble, and that causes problems. And a lot of times that will cause severe back pain. High risk, heavy lifting, twisting, or whole body vibrations. Using a jackhammer puts you at just as much risk as a disc herniation than lifting a 300 or 400 pound patient. Children, scoliosis and juvenile rheumatoid arthritis both put children at risk for this. Yes, children can herniate a disc. All right, pregnancy. In pregnancy, we redistribute our weight. We have a lot of weight in front of us, which puts a lot of stress on that lower back. Many women will herniate their disc during pregnancy. Social factors, depression. Well, depression, we stay in bed a lot, we don't move around a lot, and then all of a sudden the days we feel good, we want to get out and do all sorts of stuff, but our body is tense. We haven't limbered up, we haven't warmed up, so therefore we overdo it and we have a chance of herniation. The heavier we are, the more likely we are to herniate a disc just because of the weight that we carry and the strain we put on our muscles. And of course, genetics. Some people are genetically prone to herniating their disc. All right, so herniate in the vertebral column. Our vertebral column is made up of 33 spongy discs and are classified into 4 distinct areas. We've talked about this. We have the cervical spine, which is 7. Thoracic spine is 12. Lumbar 5, and sacral spine. Then we have the coccygeal spine, which is 4. And this is actually fused into one, the coccyx. Prior to birth, our spines are C-shaped. So if you see right here, this is in this, it's C-shaped. But in an adult, this changes as we grow. We have 4 distinct curves. 1, 2, 3, 4. And anywhere, so you see right here where most of these occur, this curvature, this is one of the reasons why we're more likely to herniate in this area as opposed to up here. Especially since we try, as we age or we don't work out or stuff, our muscles tend to weaken down in here. All right, the nucleus pulposus, the NP, is the center except in the lumbar. It lies directly on and slightly posterior in the spine. Sorry, guys. It's a gelatinous mass, lots of water, which is reason why it starts to herniate as we get older and we lose moisture. Rich in water binding PJ or proteoglycan, or also known as aminoglycose, sorry, and it's a protein molecule. Chondroitin 4-sulfate in the molecule gives a disc of fluid, maintaining its capacity. Okay, this decreases with age. Hydration is important. We can actually help this by trying to stay hydrated. Hydration in the disc will decrease with compressive. So it's sort of like we put this disc on, and as we age, we put pressure, and we just sort of squeeze the fluid out of it, which then causes the disc to narrow, which then causes bone-on-bone rubbing. Okay, so the intervertebral disc makes up 20 to 30% of the height of the column. And the thickness varies from 3 millimeters in the cervical to 5 millimeters in the thoracic. And that stands to reason because our thoracic actually takes a lot more of our weight than our cervical. Although, since we only have 3 millimeters in our cervical, we tend to lose that quicker than we do any of the others. And of course, down to the lumbar, it's 9 millimeter, where we actually do distribute most of our weight. The ratio between the vertebral body height and the disc height will dictate the mobility between the vertebrae, meaning is that it gives us this padding and cushion. When this padding and cushion is over, we have bone on bone. So right now, this can go like this, this, and this, but when it shrinks and we have bone, there's no movement in this because we don't have that cushion anymore. Highest ratio in cervical regions allow for motion, lowest ratio in the thoracic region limits motion. So again, you see this, if we have this here, this can sort of move, but once that's gone, there's no movement in it. The disc structure is 80-90% water, as we discussed before, and it decreases. The disc volume will reduce 20% daily, and you can reverse this by keeping up muscle strength, exercising, drinking plenty of fluids and such. However, we can lose 15 to 25 millimeters of height in the spinal column alone. So you see, this is how we start out when we're young. And now as we age, it gets worse and worse until this is how we are when we get older. This is just another part of something that I like to say for when we talk about disc herniation and disc degeneration or degenerative disc disease, we're talking about the exact same thing. Don't get confused at thinking they are two different things. They are the exact same thing. So we have disc degeneration right here, okay? So now in stage 2, it's bulging out, but not too bad, it's still intact. Now we have a complete extrusion here, and now when it's dripping down, we have a sequestration. In this case, we have to take out the entire disc. In this, we can try to clean it up, and this, we can try to clean them up. But this, there's no saving it once you get to 4. So, signs and symptoms of it. Cerebral spine, C4 through C1 through C4. Sorry, guys. Pain in the neck, shoulders, and interior arms. But you can also have weakness. Because remember, if it's impinging a nerve, it's going to cause weakness of the muscles because the nerves innervate the muscles. C5 through C6, pain in the neck, shoulders, lateral arms, and hands can cause reflex changes in the biceps. C6, C7, pain in the neck, shoulders, medial scapular, lateral arm. And C7 through T1, you can read this. When it gets down to C6, C5 through C7, this can actually cause a lot of problems. My son-in-law, in fact, his was so bad that he actually lost the use of these fingers in through here. When he held out his hands, his fingers went to this. He couldn't control these fingers anymore because the nerve was so damaged in so many different vertebrae that he actually lost use of these fingers. Thoracic disc herniation symptoms would be pain in the upper back, numbness pain or tingling in the upper back and around the chest, leg weakness and chest pain. But we don't see a lot of herniated disc in the thoracic region just because of its anatomy. Again, we see more of it lumbar and we see more degeneration in the cervical. But if we're going to hurt our back doing something, it's usually going to be the lumbar. So lumbar 4 through 5, we've got weakness in the big toe and ankle. We get foot drop. Numbness and pain in the top of the foot, pain radiating into the buttocks. L5 through S1, loss of ankle flexion, weakness in the ankle, push. Very important to push those ankles. And numbness and pain can radiate down into the sole or outside of the foot. So how can we test these? Well, we could do the electromyography. Do we have nerve root involvement? Are our nerves working? Are we sending signals to the muscles? Myelogram, this is actually, if this comes out positive, then we're going to do a myelogram, which is actually going to go in and determine how bad and which nerve is not functioning. Nerve conduction philosophy, I've had one of these, guys. It's not fun. It's not something you raise your hand and say, please let me have 5 more of these, because they actually send electricity into the nerve and you feel the pain all the way down to the end. MRI CT, because we want to know where the herniated disc is compressing and what we're looking at. And of course, we always rule out any other cause before we do this. Assessment, we always want to do a range of motion of the entire spinal cord. Where does the pain go? That's very important for you to document. What is it? Is it sharp and shooting? That's nerve. Is it dull and achy? That's muscle. Is it better with stretching? Is it worse with standing up? What is it? Numbness, loss of feeling. A straight leg lift is you lay down and you take one leg and you lift it straight up. If the pain shoots down that leg, that's a positive straight leg raise, which indicates that your sciatic nerve is inflamed. Assess the integrity of the muscles. So interventions, what are we going to do? Well, we could do a discectomy, which is removal of the herniated disc tissue related matter. Okay. We could do discectomy with fusion, which is fusion of the vertebrae with a bone graft, or a laminectomy, excision of part of the vertebrae to remove the disc. Now, this is where we talk about putting in the jack to keep the space, or a laminectomy, division of the lamina to the vertebrae. Usually, if they're going to do this, they might go on and have to do this. But any of these, they're going to take this out, but they may have to put in that jack. Now, if they have to put in a graft, you have to worry about graft extrusion. So that means that the patient comes out of surgery, they're doing fine, then all of a sudden they have this sudden, sharp onset of pain. That could mean a graft extrusion, and you must call the surgeon for that. You also need to monitor the surgical site in this. If you have an increase in serous sanguinus or clear drainage, you could have a dural leak. We're messing with the spinal cord here. They could, inadvertently nip something and stuff and a dural leak. So in that case, they're going to have to go back to surgery. We're going to have to do something because otherwise these people are going to get a spinal headache and some other problems. So that's a problem. So minimally invasive procedures, well, we can do chemonucleolysis, which is an enzyme derived from the papaya tree that we put into the disc. We can do endoscopic. A large needle is inserted to your back to remove parts, so we sort of suck it out. We can do, of course, bed rest. And usually if we put bed rest, we tell these people that they need a firm mattress to help relieve pain. So they need a firm. Soft mattresses give no support. We can do traction, braces, heat. We want to maintain good alignment, educate the patient on analgesics. I see a lot of these people who get addicted to pain medicine just because their back hurts so bad. And once you do a fusion, you're done. And fusions fail anywhere from 20% to 80% of the time. Educate the client, avoid flexing, extending, and rotating the neck, and of course, avoid prone position. We also give heat for muscle spasms. Sleep on your side with hips and knees flexed and a pillow between them because that helps with the alignment of the hips and some kinds of nerves compressions. We want to progressively ambulate them. Usually PT is going to do them. And if we do traction, although I have to say we don't do traction very often anymore. So NSAIDs, muscle relaxers, small bursts of steroids. We can go in and inject steroids right into the area. These last longer, but you can only do that maybe once a year, maybe twice. Narcotics, but again, we have to be careful because a lot of these people end up addicted to narcotics because they take so much of it. We've talked about physical therapy, massages, hot cold therapy, TENS units, which you can buy at the mall now, believe it or not. And of course, hydrotherapy. And we talked about a firm mattress. Okay, so nucleoplastic, we use heat-producing technology to create an energy field that decreases pressure. Oxygen ozone therapy, we put gas in to try to help reduce and sort of lift up the disc. We replace it with a prosthetic functional activity called a jack. And I wish I had a picture of it. I was going to try to find one, but things happen. But hopefully I could try to find a picture of a intervertebral jack and put it up online for you guys to see. And of course, cell engineering. We always look at that too. Post-op care. In cervical, we always monitor respiratory because at C3 and C4, we worry about that diaphragm. If we start having a lot of swelling and stuff, you're going to have a problem with the innervation of the diaphragm, and these patients go into respiratory arrest quick. We need to cough and deep breathe to clear our lungs. We don't worry, especially in this, we usually go through the front of the neck through here, or they separate the vocal cords. So therefore, if the vocal cords are traumatized at all, we need to check, can we talk? Are they hoarse? Are they not? A lot of what you see with me and my voice has changed is due to intubation from the surgery because of the vocal cords. Soft diet because we're going to have a lot of swelling through the neck. We don't want anything hard to swallow. Monitor when return for the radicular pain. Again, that could have been an extrusion and we need to call the surgeon. The lumbar, we always look for wound hemorrhage. We monitor our lower extremities for sensation, movement, warmth, cold. We always worry, are they retaining urine? Because remember, our bladder is innervated with nerves, and specifically the detersion muscle, which actually, if the detersion muscle doesn't work, then we don't empty our bladder. So we have to worry about our bladder functions. If they've had surgery, you log roll them so we don't hurt the site. And of course, we don't want to do extreme hip flexion with these people. All right, I know this has been quick. Remember, you can email me questions and I will answer them as quickly as I can. If it is burning and you have to have it up until 8 o'clock, you can text it and I will get back to you guys as quickly as I can. Hopefully this helps and we will continue on. Bye.